Okay, so I'm going to go over Sam's treatment and assessment. So again, Sam is a 27-year-old Caucasian female. Sam has lived in Connecticut for the first 7 to 8 years of her life and then moved to the Roanoke area. Sam lives with her mother in Roanoke. Sam has a younger brother that lives in Richmond, Virginia, and Sam does not have a relationship with her father, and her grandparents are deceased. The reason why Sam does not have a relationship with her father is due to an incident when she was physically struck by her father, and Sam's mother walked in and witnessed the incident. Sam told me during our diagnostic interview that she did not remember the incident, but Sam's mother divorced her father and moved to the Roanoke area after that incident. So Sam has been in this area for about 20 years. Sam is very close to her mother, but she stated her mother tries to keep her and her brother sheltered. According to Sam, she does not have any medical diagnosis in her lifetime. Sam goes to the doctor about once a year and only when she feels really sick. To Sam's knowledge, her parents do not have any medical diagnosis. Sam does not have any behavioral or mental health diagnosis at this time. And to Sam's knowledge, neither of her parents or grandparents have had any behavioral or mental health diagnosis. And again, this is based on Sam does not have a relationship with her father, so something could have changed over the last 20 years, but this is only to her knowledge that she has at the moment. Sam became into services because she recently began to feel bothered by the routines she feels she has to keep every day. So Sam stated that she has to do everything 4 times, and her day begins with her checking her straightener 4 times each morning to make sure it's turned off. If Sam forgets that she has checked 4 times, the process of checking 4 times begins again. Sam states that even if she gets to her car, so she's already checked 4 times, everything's fine, she will have to turn back around and go to her house and check the straightener again 4 times. While she's at work, she'll repeatedly pray in increments of 4 that she's turned off the straightener and to ease some of her worries. So she'll pray she'll pray and then she'll continue to pray in increments of 4. So she'll pray 4 times. Obviously, Sam is very fearful that she may leave the straightener on and create a fire. She's concerned that if she creates a fire, that not only will the house burn down, but then she has animals at home, and their animals will come to harm because of a fire. At work, Sam knows she goes to the refrigerator. When she goes to the refrigerator at work, like to get out her lunch at work, she has to check the refrigerator 4 times to make sure the refrigerator door has been closed. If Sam feels too worried about leaving the refrigerator door open, she'll continually pray or count to 4 repeatedly. At night, Sam repeatedly has to check her purse for her wallet and her car keys. She does that 4 times. Sam says she wakes up out of her sleep to check her purse and to make sure her wallet and keys are in her purse, but still accessible. Sam is losing sleep because of her repeated need to wake up and check her purse. So again, at night, Sam is concerned that there's going to be a fire. And if there is a fire, Sam wants to get out quickly. And so her checking her purse for her wallet and make sure her keys are in a place that she can reach them pretty quickly is causing her to wake up. So again, at night, she does have the same fear of fire, that there's going to be a fire. So Sam stated that when she was younger, she got to start getting her hair straightened about 11 to 12 years old. And she knows that her mother had some similar behaviors. Her mother straightened her hair when she was about 11 or 12, but Sam said she noticed that her mother had some behaviors that she repeated quite often as well. Sam she didn't know that there was like a number that she tried to get to, like in Sam's case, it's the number 4. And Sam also stated that the number 4 is her favorite number, so that could explain why she's counting to 4, why that makes her feel at ease. But she did notice her mom did repeat some behaviors, but she didn't go into any further detail than that, or she may not have any other knowledge other than she noticed her mom. Sam is very concerned that her needs to repeat the checking of the straightener and the refrigerator and her purse will continue to negatively impact her life. So Sam's already realized that the loss of sleep is impacting her. The need continually to check at work is impacting her. And trying to get out of the house and go to work in the morning is negatively impacting her. So moving on to Sam's strengths, Sam has a good relationship with her mother, so there is a support system. It may not be a very big support system or a big family system, but she does have support. She's very close with her mother. Sam recognizes that there is an issue and she seeks treatment. Sam does not have medical history or behavioral health history at this time, and Sam is employed. Some of Sam's risk factors include she only has a relationship with one parent because of her parents, of course, was divorced when she was about 7 or 8 years old. That could also be a source of a source for her issues of the divorce when she was very young. Her parents divorced. Sam's mother tries to keep her sheltered. She may be too dependent on her mother. We didn't get to explore that relationship too deeply. Sam's mother may have had similar repetitive behaviors in the past. Sam was abused as a child, even though Sam doesn't remember that. Her mother told that she was abused, and it was the source for her parents divorcing. And Sam's current issue has impaired her ability to function at work and to get sleep. If that continues, she continues not to get sleep, her quality of life can be affected, her employment can be affected. So Sam, while she has noticed or she recognizes that this is an issue, if it goes untreated, then it can continue to affect her at work and her quality of life. Based on what Sam told me in her diagnostic interview, I have diagnosed Sam with obsessive compulsive disorder with good insight. And we're going to talk a little bit more about why I felt this was the right diagnosis. So what exactly, according to the DSM, what exactly is OCD? Obsessions are unwanted, intrusive thoughts, images, or urges that trigger intensely distressing feelings. The individual attempts to ignore or suppress such thoughts, images, or urges, or neutralize them in order with some other thought or action. Compulsions are behaviors an individual engages in to attempt to get rid of the obsessions and to decrease his or her distress. The individual feels driven to perform in response to the obsessions or according to the rules that must be applied rigidly. So examples, repetitive behaviors are hand washing, ordering, checking, mental acts, praying, counting, repeating words. So we see with an obsessive compulsive disorder is that one, there's a thought or image, something that you can't see, so a mental act, and then there's a behavior that's associated with the mental act, but the compulsion is used to alleviate the stress or the anxiety that the person may be feeling. So according, the DSM has diagnostic features, and I'm going to go through those briefly. So the first diagnostic feature is the presence of obsessions or compulsions. B, obsessions or compulsions are time consuming, so they take quite a bit of time. So the DSM gave an example of an hour or more. Or these obsessions or compulsions cause clinically significant distress impairments in social, occupational, and other important areas of functioning. C, OCD symptoms cannot be attributed to the psychological effects of a substance, drug abuse, or medication, or any other medical condition. D, the disturbance is not better explained by symptoms of another mental disorder. And then the severity of OCD varies with good or fair insight. The individual recognizes that OCD beliefs are definitely or probably not true and that they may or may not be true. With poor insight, the individual thinks OCD beliefs are probably true. With absent insight or delusional beliefs, the individual is completely convinced that OCD beliefs are true. Or the individual may have a tic disorder. The individual has a current or past history of a tic disorder. So the reason why I diagnosed Sam with OCD is Sam has repeated thoughts, fears that her home will burn down. Sam attempts to alleviate this fear by repeated behaviors such as checking her straightener 4 times. At work, Sam fears that she may have left the office refrigerator door open and then must check the refrigerator door 4 times. Sam is fearful that she will leave the door open and ruin everyone's lunch. At night, Sam's fear of her home catching on fire prompts her to make sure her wallet and keys are in purse 4 times. Sam is sometimes awakened by this fear and begins the process of checking 4 times throughout the night. Whenever Sam feels overcome by worry or fear of the potential fire or leaving the refrigerator door open, she'll pray 4 times and count 4 times repeatedly. Sam's worry and fear have caused her to lose sleep and productivity at work. Sam doesn't have any other mental health diagnosis or a medical history that we could attribute to these symptoms. Sam was physically abused as a child by her father, and Sam's mother may have had similar OCD symptoms in the past. DSM-5 does attribute biological or environmental factors, does consider those two in diagnosing someone with OCD. So we see that Sam does have some issues with repeated behaviors, and these are very time consuming. They've affected her at work, they affected her at home, they affected her sleep, But Sam does recognize this is the issue. That's why I diagnosed her with good or fair insight. That she knows that these are issues for her. So she's not in denial about the issues. She's very upfront, and she does have a good knowledge, a good base that these are issues for her. So some common interventions include cognitive behavioral therapy, eye movement, desensitization, and reprocessing, and medications, and those are commonly antidepressants. So the typical method for cognitive behavioral therapeutic method is exposure and response prevention. So this method of CBT allows the client to be exposed to thoughts, images, urges that produce anxiousness, worry, or any other associated discomfort. The client in turn attempts to not respond to discomfort with a compulsive behavior. As the client progresses, they may be able to transition to exposing themselves to their own triggers and not rely solely on a therapist. So for using the ERP, Stanford Medicine has a pretty detailed list or detailed checklist that a therapist would use, and I'm going to go over those right now. How would I use these, and why, and what methods would they achieve by using these? So first of all, the therapist would explain the rationale of the therapy. The patient must agree to tolerate the discomfort associated. Secondly, we would analyze and understand the relationship of compulsion to environmental factors or other factors that increase or decrease the compulsion. So what factors are associated with Sam's discomfort or Sam's stress? At this moment, we know that there's an issue. There could be potentially an issue with a fear of fire, or there could be an issue with a fear of disappointing someone or harming other people with a refrigerator at work. The therapist would then document what the patient avoids doing or exposing themselves to in order to avoid the anxiety. We would analyze the thoughts, images, and impulses that increase anxiety or compulsions. For Sam, I would want to know more. Like I stated before, is there a connection to fires, or is there a connection to disappointment? And we don't know exactly the circumstances that revolve around the physical incident dealing with her father when she was 7 or 8 years old, but that incident could have led to some of Sam's OCD symptoms. So we don't know, but I would want to explore that more with ERP. So then we would construct a hierarchy of compulsions and avoidances from least to the most anxiety-provoking. And then, like I stated before, we could design homework that the client could do some of these at home and would not need just my help to do that. She could potentially expose herself to some of these triggers and learn proper coping methods for those triggers. According to Stanford Medicine, again, 65 to 75% of clients are improved or much improved from using ERP for OCD symptoms. So with using the ERP, there are a couple of methods you can go about implementing the ERP. And the first one is symbolic. So the therapist will use pictures or props to simulate anxiety-provoking stimuli. So it wouldn't necessarily be, something that's real. It could be a picture or a prop. Simulated would be role-playing. So the therapist and the clinician would role-play something that's anxiety-provoking for the client. Or the therapist could use real life situation or stimulus. So it wouldn't be a prop, it wouldn't be role playing, it would be actually whatever the client's fearful of, the therapist would use in session. Another very popular treatment for OCD is medication, as I stated before. It's antidepressants or SSRIs. One of the most popular and probably one of the most studied is clomiprin. And that, like I said before, that's one of the most studied and effective drugs for OCD. Side effects include weight changes, memory loss, vision changes, anxiousness, dry mouth, nausea, loss of appetite, and sleep problems. Medical doctors saw about a 40 to 50% decrease of OCD issues in about 60% of patients over a 10 to 12 week periods. So if a person doesn't respond to the medication, they could use the medication in conjunction with therapy, behavioral therapy. And so that has been seen as an effective method. One of the other interventions that I mentioned was eye movement, desensitization, and reprocessing. And I'm going to go over a little bit about what that looks like. It's not something I would necessarily use with Sam, but it is a popular method. And EMDR is seen as it may be as effective as CBT. It was originally designed to alleviate the distress associated with traumatic memories. Studies have shown that EMDR can produce the benefits of psychotherapy and not nearly as much time as some psychotherapy treatments can take. So some studies saw an 84 to 90% of single trauma victims, those victims with only one source of trauma known, they no longer had PTSD symptoms after 30-minute sessions. So after 30-minute sessions using EMDR, PTSD symptoms had gone away. And this treatment is recognized by the APA and the World Health Organization as an effective form of PTSD or trauma treatment. And so trauma or PTSD can be a component and can lead to OCD-like symptoms. And that's why I included this in part of the intervention. Not something I would necessarily use with Sam. I'll more than likely use ERP with Sam. But if ERP didn't work and we need to try something different, EMDR would potentially be something I would look into for Sam. So if we had more time with Sam, other than the brief time we had together, some other diagnoses that I could come up with is anxiety disorder. Anxiety is a common theme in OCD symptoms and people that suffer from OCD. Most of them have some type of anxiety or some worry or some strong association with anxiety or worry or stress. Major depressive disorders can also be people suffering from OCD can also be diagnosed with that. Other obsessive compulsive disorders, hair pulling, eating disorders, all that stuff can be, a person can be diagnosed with that as well. Psychotic disorders, obsessive compulsive personality disorders, and again, PTSD. So someone with OCD, if you spent more time with them, if I had more time with them, it can be diagnosed with a host of different things. So some special considerations that I would keep with working with Sam. Again, I would want to know more about the physical abuse that she experiences as a child. I would potentially ask her mother about the mother's take on that incident, if Sam was okay with that, allowing her mother to come in and talk about that with Sam. So I want to know more about that, because the DSM does contribute some of the OCD symptoms, or children experiencing physical or sexual abuse has an increased risk for developing OCD. OCD can be influenced by genetics, and Sam's mother, according to Sam's mother did have some repetitive behaviors. I would want to know more about that in treatment planning, assessing Sam. Females are more likely to develop OCD or tic disorders. And so Sam does fall into that category because Sam is a female. So those are some things I would consider. Also, dealing with Sam, I would also make her aware that people with OCD have higher rates of suicidal ideations and suicidal attempts. Sam, we didn't talk about Sam's any of Sam's suicidal ideations or suicide attempts in the diagnostic interview. But that's something that I would definitely consider in treatment planning and working with Sam for a longer period of time. I may have to safety plan with her to make sure that she is not in a place where she would do herself harm or commit suicide. Also, if I was working with Sam for a longer period of time than I was in our diagnostic interview, I would also use some obsessive compulsive disorder assessments. And some of those include the Florida Assessment Compulsive Inventory. And this is a symptom checklist. It has 20 items, and it has a severity scale of 5 items. One of the most original and most used obsessive compulsive disorder scales is the Yale-Brown Compulsive Scale and Obsessive Compulsive Inventory Revised Scale, which is 18 items, 6 OCD subtypes, and may be appropriate for research and clinical usage. Like I said, if I had more time with Sam, and got more history and worked with her a little bit longer in assessment, I would potentially use these assessments to make sure that this was the right diagnosis. But like I said, there are other diagnoses that can be assigned after longer time with Sam, and someone may see something different than I did. But that's basically my treatment and the assessment of Sam.